Hello everyone. Can you guys all hear me? That's good. It's kind of a weird experience here. It's like a silent cinema. So if you guys are smiling or nodding, I know that you guys can hear. My name is Ratnarajan, and I'm a consultant in East Grinstead in the UK. And I'm going to talk a little bit about ECP and some of the new things in combination with MIGS. These are my financial disclosures. So the title of my talk is A New Light on ECP. We'll start off by talking about some of the things that you probably already knew about ECP. So ECP is arguably the first MIGS procedure. It's used to treat patients with mild to moderate disease, and it's very useful and easy to do at the same time as cataract surgery. It can be performed as a standalone procedure, particularly in the pseudophakic or aphakic eye. It works by reducing the intraocular pressure, by treating the ciliary body epithelium, and therefore reducing the inflow and reducing the aqueous production. So the mechanism of action here you can see a picture of the ciliary processes, and you've got the pigmented ciliary body epithelium. Using a low energy diode laser, the ECP laser ablates this and gently turns down the aqueous production. So this is what the actual technology looks like. On the right here, you can see, on the left here, you can see the housing system, where you have the 810 nanometer diode, as well as an aiming beam and a high resolution video. So you're not looking through the microscope where you do your cataract surgery, but you're looking at the separate screen that you have there. You've got a very good xenon light source as well. And then within this probe, you have the light source, the image guide, as well as the diode laser. I put a little note here that it's particularly useful in the unit that I work, which is a specialist corneal unit where we often deal with opaque corneas. So you can do it to visualize the anterior chamber angle. And if you're brave, you could even attempt to do cataract surgery alongside that. So the actual technique, assuming this is done in conjunction with cataract surgery, you would implant the intraocular lens and then remove the viscoelastic from the bag. Then using a cohesive viscoelastic, you would then inflate the ciliary space. It's important to get a good space here because you want to see the entire ciliary process, including the zonules, to avoid treating other areas, which we'll come on to talk a little bit about later on. So some nice videos running alongside this slide here. Generally, we start with a power of 250 milliwatts, which is about a sixth or less of the energy you would use using transscleral cyclophotocoagulation, so much lower energy settings. And the reason, obviously, is because you've got a direct visualization of where you're treating. Here you can see with the depiction, and in the top corner, you can see here the process of treating the ciliary processes. So it's a slow, gentle application. You want to treat from the tip up to the top of the ciliary processes, allowing for it to shrink and whiten. Here you've got a good view, so you can see the zonules below, and you can see the undersurface of the iris above. And it's important to have that visualization so you don't treat either the zonules or the underside of the iris, which could lead to unnecessary pro-inflammatory response. Depending on the level of disease, it will dictate how much of the ciliary processes you treat. You can treat the whole 360 degrees, depending if you use the side ports of your phacoemulsification. Using a curved probe can often give you a little bit better access, particularly if you're thinking about just doing a single site ECP treatment. Post-op regime, this will vary from person to person and surgeon to surgeon. This is what I use in my unit. I give some intracameral dexamethasone, roughly about 0.2 of a milliliter, and the rest of that I give subconjunctivally at the end of the case. I give Maxidex every 2 hours for 1 week, and then 4 times a day for 3 weeks. If they are diabetic or have other risk factors, which may be pro-inflammatory or for cystoid macular edema, I may give some non-steroidals as well. There's a lot of debate out there about whether to give post-op Diamox. I see my patients on the same day, a couple of hours after the surgery. If there is a pressure rise, I'll decide whether I may give that dose or a couple of days worth of Diamox. But really, I'm seeing very little in the way of early IOP spikes at day 0 and day 1. So my routine practice is not to give Diamox at the time of the surgery and in the immediate post-op period. But I know many of my other colleagues in the UK might do that. So let's look at some data. This is a nice study because it's got long-term data up to 72 months, which is rare to find in the published literature. Here you can see the intraocular pressure has reduced, so it's not projecting that well there, but it's dropped from 17 down to just under 14 millimeters of mercury out at 72 months. There's been a good drop in the medication usage from 1.26 medications to just 0.25 medications. And this was a study where it was combined with cataract surgery. So that was some stuff that you probably knew already about ECP. Next, we're going to talk on to some of the newer things that you may not have known about ECP. Start off with ECPL, endocycloplasty. This is different to photocoagulation because you're not treating the whole ciliary process from tip to top and with that shrinking effect. You're just treating the tip of the ciliary processes. The aim here is to rotate the ciliary body backwards, and it's particularly useful in patients with plateau iris. I'm not sure whether you've done cataract surgery in patients with plateau iris, and even after the surgeries, they still have that steep insertion afterwards. And the angles, yes, they are more open than they would have been before the cataract surgery, but you still have that steep insertion and potential for occlusion. So by treating the ciliary processes, you rotate the ciliary body back. The aim here is not to reduce aqueous production or to lower the intraocular pressure, but to change the anatomical configuration of the anterior chamber. And Vanita Pathai Ray has done a nice study and published this work. And you can see here the deepening of the anterior chamber angle, particularly at the iris root insertion with OCT images there. Combining MIGS. Does combining MIGS give you a post-op hangover? I'm a believer in trying to avoid bleb surgery if you can. You wouldn't want a bleb in your eye or a family member's eye. Sometimes you need a bleb, of course. If you have truly, progressive disease, you need low target pressures of 10, 11, less than 10 for normal tension glaucoma, you need a bleb. But if you can avoid a bleb, I think, that obviously has huge implications on patient quality of life, the post-op recovery, and many aspects. So a surgery that we've been doing a lot of over the last couple of years is the ICE procedure, or we call it ICE 2, where you're doing eye stents, but this is with the eye stent inject, so 2 eye stents, then the cataract surgery, and then followed by ECP. What is the rationale behind that? Well, the eye stent is to improve the outflow through the trabecular meshwork, allowing a direct communication between the anterior chamber and Schlemm's canal. The ECP is to lower the aqueous production and therefore lower the intraocular pressure, as well as opening up the drainage angles, which we talked about. It's important to not forget that cataract surgery will also lower the intraocular pressure and can also open up the drainage angles. And the next point is very unique amongst glaucoma surgeons, is actually an improvement in the vision. We've all come across the trabeculectomy patient where we've got great pressures, they're 6.6 before the surgery, they're 6.6 after the surgery, but they're unhappy. They're not quite seeing so sharply, their eyes are sore, it's uncomfortable. Here, patients are coming with improved vision because you've removed their cataract, and they're happy patients, and happy patients make happy doctors. So that's an added bonus to the surgery. So here is a short video of the surgery. I like to do the eye stent under direct gonioscopic view before the cataract surgery. I feel the view is better, and you can see the direct view. And here's the ECP done after the lens is implanted. If you note here, this is one of my earlier ECP videos. The amount of treatment that I'm doing here for the ECP is less than what you saw in the previous video. When I started off with ECP, it was new to the unit, and I was quite conservative in the amount of laser energy that I applied to the ciliary processes. I've been getting no inflammatory reactions, no fibrinous uveitis, no IOP spike. So now I've become more confident to increase the amount of energy and the treatment that I apply to the ciliary processes, particularly with the intracameral dexamethasone. That does help to quieten things down very early on. So the ICE technique, as I said, I'm probably in a minority that I actually do the eye stent at the beginning of the surgery. I then remove the cataract, place the lens. It's important then to remove the helon from the bag It's a temptation just to try and inflate the ciliary space, but you won't get enough space to allow for the full treatment, and then you run the risk of treating the underside of the iris. So evacuate the OVD from the bag and give yourself a nice big plane to do your ECP laser. I like to use a curved ECP probe. It gives me a good approach, particularly if I'm just doing through the main incision, where you can probably treat 240 degrees just through the one incision. As I said, I like to give intracameral dexamethasone. Intensive steroids for the first week. I see them at week 1, and these eyes are as quiet as if they would have had just a cataract surgery at week 1. And then I'll reduce the dexamethasone down to 4 times a day for the remaining 3 weeks. So what are the results been like? This is a snapshot of the results. I will be presenting this in a presentation tomorrow afternoon, so do feel free to come along. But a snapshot is very encouraging. So we looked at 2 groups, the ICE2 group and the phaco eye stent group. And we've got excellent results. We've got pressure reduction down to 13 millimeters of mercury, with 2/3 of patients being off medication or just on one class of medication, starting with a pressure of 20 millimeters of mercury. So very happy. In terms of this group included 65 patients. We've had 2 cases of cystoid macular edema. Both of them were on patients with prostaglandin analogs. But also the phaco eye stent group also had 2 cases of cystoid macular edema, all resolved when the prostaglandin analog was stopped, and they were treated with non-steroidals. So what else do we have in terms of the literature when you look at ECP combined with other MIGS? Not a lot really, and I think this is a space for potential future work and potential studies, and certainly something that we're going to be looking at in our unit. So just looking through what's out there, a lot of this is just posters or presentations with just one published paper. So starting at the top, you've got a presentation with phaco, Cahook dual blade, and ECP. This is 27 eyes with just a 6-month follow-up. The pre-op pressures were not that high to start with, 17 millimeters of mercury, but there was a good reduction in pressures down to 11.9 millimeters of mercury. Again, a good reduction in the drop usage, with 70% of patients becoming off their drop. The Cahook dual blade is a fairly new MIGS device. Within this abstract, they did talk about quite high levels of hyphema at day 1 and week 1, but all of them resolved without any complications and were treated conservatively. The next one is a poster that I presented at UKEGS, but that was the 6-month data. I've just presented you the 1-year data for that cohort. Then we have a published study looking at the eye stent first generation, so a single generation eye stent combined with cataract surgery and ECP group, and they combined that with just a phaco eye stent group. The pressure reduction in the phaco eye stent ECP group was down to 14 millimeters of mercury, with a good drop in the medication usage from 1.7 to 1.1. In the phaco eye stent group, the pressures were 20 beforehand and down to 16. So getting a couple millimeters of mercury more reduction with the ECP in that group. Another American study by Ronald Coronia showed less impressive results with a similar surgery, where the pressures went from a pre-op pressure of 18 only down to 16.5, but there was a good reduction in drop usage from 2.3 down to 1. And I guess the questions that are remaining in this space is, what is it best to combine ECP with to avoid that hangover? For me, the eye stent or treating the outflow seems to be a natural process, because one treats outflow, the other treats inflow. Both are very safe procedures. They're not pro-inflammatory. What maybe the Cahook dual blade maybe, but the eye stent certainly isn't. And we've been getting very encouraging results. How much ECP to do? Again, that comes down to your usage and from your experience. Generally, if a patient has got real moderate glaucoma, I will treat 300 degrees worth of ciliary processes. But if they've got mild disease, I might only treat 210 or 240 degrees. And in the study that we showed, we did show that by treating more angle, so going up to 300 degrees, we were getting more pressure reduction than just treating 180 or 210. So I hope that's provided a little insight in endocycloplasty and also what's new, and potentially a flavor of what may be coming up in the next couple of years within this sphere.